much from just reading literature. Obviously, I'm not a scientist and I don't follow and I don't do the cow treatments and whatever not, but what I know is very much on what I've read. So if I'm wrong or if I'm mistaken or it's not really the most updated thing, it's good to share. Yeah. So, going to this. So, one of the first few medical reports I had to write when I was a first year registrar was on someone that had needed a committee of persons for dementia. Like everyone else, I asked Prof. Chiam, can you give me a template? Right, so just copy and write. And the template actually stated this. He's suffering from Alzheimer's dementia, which is irreversible, incurable disease of the brain that will deteriorate with time. As a result of this dementia, he has marked impairment of his memory, intellect, personality, and judgment. I don't know whether anyone got the same template, has been using this, but I'm still using this when I'm writing such reports. Okay. The challenge is that the present day treatments are only marginally ameliorate the cognitive and behavioral aspects of Alzheimer's dementia. The drugs at this present time try to improve and preserve the existing neurons, and the medications that are approved are that of cholinesterase inhibitors as well as the NMDA receptor partial antagonist. Okay, this is what happens in the brain in a few words of cholinesterase inhibitors. Essentially, there are presently 3 on the market, which you know, and they respond measures to, and they show to have response to the ADAS cog improvement in that, and it's actually useful in early dementia. Which drug would you actually choose? It's really very dependent on your experience and what you like to use, what you have been more familiar with. Initially, I had liked to use donepezil because it's very easy to dose. Once a day, don't have to multiple dose. So unfortunately, or fortunately for Ariset, I've been using that most of the time. Now rivastigmine comes with a patch, even better. Don't have to bother the patient to swallow. So I favor Exelon at this point in time, all things being equal. But at the end of the day, it's really a class of medicines that are useful. Galantamine, Rimonil, actually says that there's a nicotinic receptor antagonist, and therefore says that it's superior to the both, but I don't see that being the case, and very much it's still multi-dosing, and that's why I seldom actually use galantamine. Okay, and as mentioned, it's usually done used in the early phases of the illness, and it works basically on the cholinergic neurons in the brain that spreads everywhere, from the basal forebrain to almost all parts of the brain. So essentially, that is what actually is done. It is with that. So maybe we'll go on to the NMDA receptor antagonist. Essentially, it acts on the glutamate NMDA site, and it acts on the glutamate receptor. I will just show a short video on this that will be rather self-explanatory.
Glutamate is the principal excitatory neurotransmitter of the central nervous system. Glutamate is stored presynaptically and binds postsynaptically to glutamate receptors. These include NMDA receptors, which play a decisive role in learning and memory development. An NMDA receptor controls a calcium channel and regulates the calcium-ion influx into the neuron. At rest, the ion channel of the NMDA receptor is blocked by magnesium. During activities, glutamate is released into the synaptic gap. Magnesium leaves the ion channel and calcium can flow into the postsynaptic neuron. In case of a very low glutamate concentration in the synaptic gap, there will be a certain amount of background noise, but no neurotransmission. Magnesium leaves the calcium channel only upon activity and a temporarily high glutamate concentration. Then calcium can flow into the neuron and the resulting signal is recognized. One of the characteristics of dementia is a chronically elevated glutamate concentration. The concentration is not sufficiently high as to be interpreted as a signal, but it opens the magnesium block so that calcium can flow continuously into the neuron, increasing the background noise. As a result of the pathologically elevated background noise, signals arising from activity can no longer be perceived. The continuous calcium influx into the neuron activates catabolic processes and results, if not treated, in neuronal cell death. This is the cause of dementia symptoms. The toxic effect of glutamate results in neurodegeneration and the progression of the disease. A functioning glutamatergic signal communication has to be re-established. Ibixa is an NMDA receptor antagonist used in clinical dementia therapy. In contrast to magnesium, it blocks the calcium ion channel also during subliminal glutamatergic receptor stimulation and reduces the elevated background noise. When a new learning or memory activity starts, Ibixa leaves the receptor temporarily. The resulting signal is recognized due to the lack of background noise and processed. In other words, Ibixa prevents an excess of neurotoxic calcium influx, improves dementia symptoms, and acts as a neuroprotector.
Okay, so self-explanatory in terms of it achieves excitotoxic glutamate, and therefore the NMDA receptor antagonist actually protects against it and therefore has activity against dementia. Okay, so challenge is that these treatments are actually rather ineffective, and the reason is because the brain is already damaged now. And by the time someone is actually diagnosed with dementia, there's this certain level of cerebral atrophy that happens, and therefore it's almost like you are flogging the cells that are already degenerated. If you think a similar situation is in Parkinson's disease, where it takes 70-80% of the substantia nigra to actually be degenerated before you see the symptoms of dementia. And that's what you see symptoms of Parkinsonism, and that's what you're seeing in dementia. So although the medicines actually try to optimize the functions of the cholinergic cells and to prevent further damage, the damage has already been done now. Okay. So what we'll go through now is actually, with more being known of the molecular mechanisms of Alzheimer's disease, it may be interesting to see what are the new ways of actually treating dementia. And I'll show another video quickly on the biology of it.
Are classic biological hallmarks of the disease. Plaques form when specific proteins in the neuron's cell membrane are processed differently. Normally, an enzyme called alpha secretase snips amyloid precursor protein, or APP, releasing a fragment. A second enzyme, gamma secretase, also snips APP in another place. These released fragments are thought to benefit neurons. In Alzheimer's disease, the first cut is made most often by another enzyme, beta secretase. That, combined with the cut made by gamma secretase, results in the release of short fragments of APP called beta amyloid. When these fragments clump together, they become toxic and interfere with the function of neurons. As more fragments are added, these oligomers increase in size and become insoluble, eventually forming beta amyloid plaques. Neurofibrillary tangles are made when a protein called tau is modified. In normal brain cells, tau stabilizes structures critical to the cell's internal transport system. Nutrients and other cellular cargo are carried up and down the structures called microtubules to all parts